morning, and if you're just joining us, this is Daily Trust TV. We're talking with Dr. Kema Onu. He's the clinical coordinator for AIDS Healthcare Foundation right here in Abuja, and we've been talking about HIV and AIDS and young people against the background of the recent UNAIDS report. So I was asking you, and by the way, you can join us. Just follow the hashtag Daily Trust TV. I was asking earlier about how all of these issues about HIV, you mentioned socioeconomic issues, how they affect young people. Now, let me go back to the report. One target is to reduce new HIV infections to less than 100,000 by 2020, and that will require reducing infections by at least 74%. Right now, the rates of reduction is nowhere close to 74%. How do you see that happening? Considering the socioeconomic issues you've mentioned, the forces that are driving new infections among young people and especially young girls.
It's alarming, like you said, but I think we should not lose hope. We are well on our way to achieve our 2020 visualize that whatever data you are getting, it's actually through some active action into reversing the trend of HIV is HIV testing services. You understand? If people come out to get tested, you understand? Those who are positive know where to go. Those who are negative know what to do. You understand? So if you don't get tested at all, if you don't do your HIV testing, there's no way. That is the entry point. So HIV testing services remains the entry point. So what we are trying to do is to what I think the way to go about it is to stimulate people to go out. HIV testing is about the only test that you do in government hospitals that is free. In every government hospital, private sectors might but if you come to any AIDS Healthcare Foundation services, every our services are free. But I'm trying to say that people should learn. They should not live in a presumptive HIV negative status. Majority of Nigerians who are married are living in a presumptive HIV negative status. Presumptive, and we do not need you. Now, the guideline says that for high risk persons, high risk persons are people who we call the most at risk population. The most at risk population, the female sex workers. We don't call them prostitutes. We call them female sex workers. The men who sleep with men. And the intravenous drug users. This is what they call them the most at risk, the key core. But for us in Nigeria, we have our peculiarities. The high risk person for us, I can tell you from my experience as a clinician, are the long distance drivers. A long distance driver is coming from Lagos to Sokoto, and he stays away from his family. He sleeps somewhere, he goes again. So that is a high. So the National Union of Road Transport Workers, their union should be focused on. A young man who's 35 to 40 who is not married, for me, is a high risk man. A high risk man. The same thing with a woman. So this population of people they must be focused on. So if you skew your HIV testing services towards the female sex workers, towards the men who sleep with men, because they have a higher risk of contracting them, they are the drivers of this HIV infection. The intravenous drug users, because most likely they will use the same needle to inject themselves. So like in South Africa and some other countries, they have what they call a one-stop shop for drivers. As a driver is driving from maybe Lagos, he stops maybe in a place like Sokoto. That stop shop, they have a HIV testing service around that place for him to do. People, those who are high risk should at least do their test every 3 months. Every 3 months. And also the negative partner in a serodiscordant couple should do it every 3 months. You understand? So if people do HIV testing regularly, I can assure you we will be able to have good data and we'll be able to stop and reverse the trend of HIV.
So we test?
Testing is about the entry point. If you don't do testing, you cannot do treatment.
That's the entry point to treatment. So after testing, what's your sense of treatment options available in Nigeria, considering again our peculiarities?
Okay, so it's something we keep changing. I was opportune to be in the 2016 review. We are moving into what they call the test and treat. Many years ago, because we didn't have the capacity to treat every person having HIV, so what did they do? They brought guidelines. They said there is a level on which your immune system, by virtue of what we call the CD4, will be. You understand? Before they commence you on drugs. The undertone for us, some of us, will feel that if you have malaria, I won't wait for you to be 1+ or 2+ before I start you on treatment. If you have malaria, I will start you on treatment. But certain guidelines was, so many things came into play. The funding available to offer free treatment, you understand, or offer free investigations for them. But luckily for us, Nigeria is planning daily to take hold of the HIV and AIDS programming. And that we are talking about, we believe that the new minister is working towards a test and treat policy where you are tested, you are positive, and you treat. We don't need to wait for your immune system to be very low. Because while waiting for your immune system to be very low, you might even die. You understand? You might even die. So what we are saying is that currently we had over 3.2 million persons living with HIV, but just about 700,000 above are on treatment. So you have about 27 to 30% treatment gap. That is an alarming figure for us, because if everybody was on treatment, see what was going to happen. If everybody was on treatment, the goal of treatment are 4 goals, amongst other goals, but the 4 major goals of HIV, placing people on care. You must tell the patient not to expect a lot from you. If you tell the person, the first goal is to bring down the virus to undetectable level. So viral suppression is the first goal of placing somebody on drugs. Second important goal is to raise the immune system by virtue of the CD4. So the CD4 should be going up, the immune system should be building, because that's what HIV does. HIV brings down the immune system. So that's why we monitor you from time to time. The third important goal of HIV is to keep antiretroviral drugs, is to keep you clinically stable. You will never be sick. And the fourth, which is a public health important or public health, is to reduces the transmission from others. So if everybody on HIV or have HIV today, are you hearing me? Is on treatment, the risk of transmitting to the next person has dropped significantly. I tell you, before 2030, 2040, we were talking about eradication of HIV in the world. You understand? That is why we say, but we cannot place you on treatment without being tested. So once testing services are scaled up, people are availing themselves for testing, and they are on drugs. Obviously, new infection rates will drop, incidence rates will drop, but the prevalence will be as it is over time. So that is our goal, is to ensure that the 30% treatment gap we are having is closed out, so that no new infection, HIV will be a thing of the past.
Okay, so let's go back to 1981. That's officially when Nigeria maybe had its first case of HIV was detected, or rather from the 80s. Officially, we've had HIV from the 80s. In all of this time until now, why is it that the knowledge about HIV and AIDS, what to do, how it comes about things like serodiscordancy, why is it that it's still not up to the point where people actually have a mental picture, a correct mental picture of what's going on?
All right, thank you. Just a correction, it was 1986. I think the first case in Nigeria was about 1986. Okay, so I must say that when I was in medical school, the one virus that we studied and studied and studied more than any other virus in our days in virology is still HIV and AIDS. I never even heard of Ebola. I just pocket Zika virus, because these were not things that were in our domain. So HIV is well studied. HIV is well studied. But I think that maybe when the idea about HIV came in, it came as just the way it was in the Bible when leprosy came in. When they saw the leper as a sinner, HIV came in, they came in and painted it so bad. They painted it to look like once you get it, it's a killer disease.
And of course,
the orientation of Nigerians were so scared. And then coupled to a country like ours, where everybody seems to be so religious, and they believe that imagine if you have a reverend father with HIV and AIDS, you don't want to understand why, you just think that he is promiscuous. So in a country like ours that is so religious, and they believe that once you have it, it means you are actually very sinful. So that has fueled it. I think they came in a wrong way to build it, and that has continually made people not to come and look. Majority of persons who are rich today do not want to go to hospitals to assess HIV because they don't want to meet anybody. They don't want to see anybody. In fact, if you have a clinic where that is so covered, people are going to flood your clinic. But once it's open, people will not come because the stigma and discrimination against it is so high. That is why our organization spearheaded the popular version of the anti-stigma bill to ensure that people do not know that, okay, today in Nigeria we have organizations who insist that you do HIV testing before you work for them. And by virtue of the law that was passed in November 11, 2014 by the Good Luck and Jonathan administration, the anti-stigma bill, you can be arrested for that. You can, you can be sued for over 2 million naira for insisting that somebody does HIV testing. HIV testing is never a prerequisite. There is no preconditional HIV testing. If there must be a preconditional HIV testing, it's only the doctor, an authority in that field that will sign. I had a situation whereby a patient was about going to surgery, and the surgeon said, you must do HIV testing before I go into surgery. I know what the patient said. I want the surgeon's HIV testing results too. I want the nurse, I want the anesthetist, I want all of them to bring their HIV results before they can even see my HIV results. So HIV testing is not, there's no preconditional HIV testing. But that's why we need to reorient Nigerians. You have, you're newly married woman, you want to bring in a young girl into your house, and you say, you must do HIV testing before I take you into the house. That is a law. There's a law against it. It's not a force. You don't sack anybody because the person has HIV. You understand? Secondly, you have issues where you want to marry. I'm saying it, you want to get married, and then the pastor says, or whoever it is says, I want to see your HIV result as a requisite for me to get you married. It is enough for you to say it is good for you to have couples together. It's good for you to know HIV status. You understand? And it's good for you to know it, but not as a requisite to join them. You understand? Most times they'll tell you they want to see their results, and you begin to ask yourself, are you going to start them on drugs as a religious leader? You understand? It's enough to advise them. It's good for you to know, but not making it as a requisite for you to go into marriage. So these are issues that are surrounding why people do not even want to think towards that. I think that the knowledge we have, the knowledge base for Nigeria, look, if you go to the very remote village, that 5-year-old girl, that 10-year-old girl most likely has heard about HIV. That's the truth. People in the village, they call it different names. In the village, they have different names for it. But I think the problem is not just knowing about HIV. The idea is that knowledge you have, does it bring about a behavioral change? If you just know about HIV and you still don't want to use condoms, that's not brought about the behavior. That is why a professor and the man who is not educated in the village are at equal levels, because the knowledge you have is not bringing about a behavioral change. You understand? So it's not a function of people know about it, but it has not stimulated them enough to bring. Look, most men don't want to use condom. From our studies, men will not want to use condom, and they forget that it's not just HIV. Condoms, contraceptive. I'm a Catholic. I keep saying it. I know that the Catholic Church has issues with contraceptive, but being a doctor, I want to be more of a doctor when it comes to health. Because when you're talking about human health, you should be more realistic than to be in an ideal world. I want to be realistic. HIV is a major issue in this country. It's a major issue, and we must fight it headlong. Preventive models, HIV testing services is the first prevention model. Using abstinence, condom, and being faithful, they are prevention models. But we must exhaust all this. We don't play politics with human lives. So I think we should be more realistic when we are talking about HIV. So the idea is not, as you said, it's not just people know about HIV, but the knowledge is not bringing about a behavioral change.
So for those of you just joining us, this is Daily Trust TV, and we are speaking with Kema Onu, clinical coordinator for AIDS Care Foundation, and we're talking about the complexities of HIV and being young. Now, I want us to dwell on young people. You just mentioned something that sparked my interest. You mentioned religion. You've been Catholic. For young people, they are across all of these spheres, in religion, in social life, in pop life even. They feel these intersections. How do they navigate this? Being Christian or Muslim, having their own religious biases against preventive models like that, things like condom, and then being in the public space, in pop culture that encourages the use of this. They want to groove, as they say. They want to have fun. How do these are these two, or rather these spheres colliding in some way?
Okay, thank you very much. You see, issues bordering on religion are very sensitive issues. People don't want to come out and talk about it. There are areas where people have been reported to have gone to this country where they were carrying out condom demonstration, and then they were sent out packing by the village chiefs, and because it's against their culture and not. So we must respect people's culture. We must respect people's religion. But what we can do as healthcare people, stakeholders in this, is begin to continually pay advocacy to these people. You see, some people believe that morality comes before health. You understand? Morality is number one, and that is the truth. We must be moral. If the country can only get it right when people are moral. But like I said, an ideal and reality, there's a gap between what is ideal and what is in reality. You understand? I am realistic, and the most realistic ways of preventing HIV. I go to clinics and I see people die. In Nigeria, 220,000 new deaths yearly from persons living with HIV. These are preventable deaths. You understand? Because I work in clinic, because I see these things, I must work like somebody who is working in a clinic, and I'm giving. So what we can do is to pay advocacy, continue to stimulate their interest to change to this thing. But we must not be very careful, because culture, religion are very sensitive issues, especially in our domain in Nigeria. We must be very careful. Areas where we go, we also try to, like for instance, if I'm carrying out HIV testing services, I will be careful to make sure that it is age appropriate. I will not be doing for children who are less than 15 years, carrying out such services for them. And I also want to, when I would advise people who go to communities to meet the community leader and hear from them. Pay advocacy visit. That is all you can do. Your limitations are there, but you cannot the barrier of social religious issues, you cannot surmount them. You can only make them continue this by giving them data, showing them data of what you are seeing here, stimulating their interest, but you will not be able to come out closely and begin to make policies across religion. That is a multi-ethnic religious country.
Okay, the questions are beginning to come in, and one of them I'm going to expatiate a bit. The question is quite simple, just a few words, but the preamble to that, we know that there are about 2 or 3 brands of female condoms on the market, and there are more than 200 brands of male condoms on the market. So if people are not using condoms, who's buying them?
That's the question. I had an experience once when we went to a hostel in a university to give condoms out to people, and nobody collected them. And then we dropped the condom in front of their hostel rooms, and the next morning there was all missing. So it's still we didn't see them. So it's still people are shy using these things. You go to a pharmacy shop, and before you say I want to buy a condom, you have to wait for everybody in the shop to have gone. Then you, especially if it's a girl, people should come out. Really, it's things that are built up. Our culture is in the interface between what we do. People believe that people use condom, but most people do not claim they don't receive sexual gratifications from condom. But why trying to promote condom use? We shouldn't let people know that. We should let people know that condom has contraceptive benefits and prevention benefits. Not just prevention, but contraceptive benefits. Pregnancy, for instance, it's something. Nowadays I begin to hear reports where even rapists now ensure that they use condom. I want to get to that level when somebody wants to rape and ensures that you use condom prior to rape. So people use condom, people are ashamed of it.
Okay.
That culture thing.
The next question is from Jummai Hassana. She's asking, can someone with HIV get married and have children?
Beautiful. Like that is something. It's a very important discussion we should have, because like I said, I run a HIV clinic center that has thousands of patients, and each time you get this same young girl and women, they keep asking you, doctor, what else do I have in life? I told you earlier today that it's up to 60 to 80% of people who are married, who are receiving antiretroviral drugs, are serodiscordant. Serodiscordant means that one person is HIV positive and the second person is HIV negative. Now the question is, if this was your brother, if this was your sister, will you advise them to go ahead with the relationship? Now I can tell you from my own humble experience is that HIV serodiscordant relationship is a safe form of relationship, where one is positive and one is negative. It's a very safe relationship. Why am I saying that? As long as the person who is HIV positive is on treatment. You understand? This is what we call treatment as prevention. The most effective prevention model
you have is treatment. If somebody, if the person who is on drug is on treatment, he has reduced significantly the chances of transmitting it if he has actually had viral suppression. You understand? So that's one mode. So people with HIV can actually get married. Now the question is, if there's nothing under the sun that is 100%, you understand? But significantly it is reduced. Some countries are promulgating for what they call pre-exposure prophylaxis. Pre-exposure is, I don't have HIV, but I take these drugs every day. Every day, yes, it's going to protect me up to 96, 90. Some the data is still changing, but under 96% chance reduction that you have HIV. So for those whose wives or husbands is HIV positive, the negative partner can actually be on a pre-exposure prophylaxis. Currently it is being advocated in Nigeria, and I believe that very soon we'll get there where everybody can get these drugs free. Pre-exposure prophylaxis. It helps to reduce the chances of them. But I can tell you, even without pre-exposure prophylaxis, from my humble study over the years, I'm yet to find one person who was HIV positive, who was on drug, who was virally suppressed, who infected the second person. So that's one. Second question is, the woman will ask, can I actually get pregnant? Will I infect my babies? And I said to you, countries like Cuba have gotten it zero. It's called prevention for mother to child transmission. Cuba went extreme and says, okay, HIV positive mothers, if you must get pregnant, you must do a viral load. You understand? If your virus is undetectable, yes, they will allow you to carry pregnancy, but they will tell you that they will monitor your pregnancy so closely. In labor, they will just ensure that you just do CS. You understand? They do cesarean section for you because the highest means of transmission of HIV from mother to child is in labor and delivery and in pregnancy. You understand? So they get it right in labor. They make sure you do cesarean section. You understand? So for countries like Cuba, it's an absolute indication for CS. Then they say no breastfeeding. They'll tell you don't breastfeed at all. So Cuba was able to get it up to 0% of mother to child. And Nigeria is hovering between 1.8%. You understand? PMCC. But I'm saying that in our country, you must domesticate issues. HIV and AIDS in a pregnant woman, cesarean section is never an absolute indication for HIV. In cesarean section has absolute indications and relative. Absolute is that once you have it, you must do a cesarean section. You understand? For instance, if I have twin gestation, one is breech. You understand? The doctor said, no, baby, let me just do a cesarean section. But in HIV is a relative indication. It's not an absolute contraindication in Nigeria. So hospitals, I would say, no matter what your HIV status, you must do. In the country, we are not so strict with that, because we have issues that how many people can even afford to do a cesarean section? How many centers? You understand? And who wants a scar? And how many people in the villages in rural places can actually have access to such cesarean section? We will make our laws across board. The issue of breastfeeding, Cuba says no breastfeeding for HIV positive mothers, and Nigeria is saying, well, what is the risk of transmitting if the mother was on antiretroviral drugs, and if the mother was born in a good healthcare center, and if the baby was provided prophylaxis at birth for 6 weeks, as you know, okay, with nevirapine, the chances of mother-child transmission is about 1.8. So low. You understand? Don't forget that breastfeeding has a lot of benefits, and if you keep a baby that was breastfed and you keep a baby that was on breast milk supplements, you see the difference is just like 7 up. The difference is clear. You see because breast milk has the first immunization in colostrum in the first day. The breast milk has a lot of nutrients that the breast milk supplements will not give you. The breast milk is being bonding. The breast milk has benefit to the mother and to the baby and to the society. I'm not going to go into the benefits of breast milk, but what I'm trying to tell you that a woman says she doesn't want to breastfeed. What we do not advocate for is mixed feeding. But a woman says she doesn't want to breastfeed. Let me say the first situation that comes. Her mother-in-law comes, or she goes to church. He sees the baby crying. Breastfeed the baby now. You know, she cannot tell the person because I'm HIV positive. So maybe when the pressure is so much, she will just put, despite the fact that she has been given the breast milk supplement, just to pacify every other person, she will begin to do mixed feeding. Mixed feeding increases the risks. So that social issue where people do not breastfeed in Nigeria is an issue. Outside the country it may not be an issue, but for us it's an issue. You understand? The issue of how much is a tin of breast milk supplements? For those who are married know that it's about 3,500 a tin. Now a baby is growing up, he needs to take things in a week.
In a week.
You understand? That's 9,000. Multiply it in a month, and then he has to. Don't forget, if I want to breastfeed my baby, there and there I can breastfeed my baby. But for me to make a breast milk supplement, I have to go and look for sterile water. I have to sterilize the plates. It's not something that you can do at your convenience. That is why they say there's a criteria for you to even tell a woman that she can go on breast milk supplement. They call it an AFAS criteria. It must be affordable. It must be feasible. It must be acceptable. It must be safe and sustainable. That's what AFAS is. AFSA. Most time they want to start. I don't want to infect my baby. And before you know it, they realize that they cannot afford 40,000 naira on the breast milk. And within 2-3 months, they have changed. So what we are advocating is give an exclusive breastfeeding for 6 months. Then you can begin to mix it after 6 months. But don't breastfeed more than 1 year.
Okay.
For HIV positive. And we are getting good results. Why we are getting, if ever we are getting bad results in our PMTCT, as prevention from mother to child transmission, we are getting it because of people in the villages, in rural area that do not. Imagine when you diagnose a woman and a man from their baby. A baby is sick. You now do a lot of tests and realize that the baby is HIV positive. You say, hey, let me go and test the mother and test the father. You will now realize, you can imagine when it's going behind the back, it's supposed to be going from the other way. You understand? So that is one of the cases we have. Women don't get themselves tested, or they don't repeat the testing in pregnancy. So these are, if you can get it right, late presentation, then we will to narrow our PMTCT. Why we still have lots of babies who are positive today is because either the mothers are not going to antenatal, or even in the antenatal service are not optimally, or they are giving birth by traditional birth attendants that are unskilled ones in the village. Those are the things that are fueling our children population who have HIV.
If watching on social media, we still have a few more minutes to spend with Dr. Kema Onu. And you can as well type in your questions in the comments box right under the video you're seeing. One person is asking, a viewer is asking, how do I know I have HIV/AIDS? I guess that's from testing, but are there any complexities around it?
Okay, so like I said to you, HIV is not a show for face. Yeah. HIV is not a disease. HIV is a virus. As you have hepatitis virus, HIV, so anybody can have HIV, it does not have it. So HIV will lead you to AIDS.
That leads directly to the third question from Samuel Oche. Okay. He's asking, do all people with HIV have AIDS?
Well, the natural history is that if without treatment, you definitely one day lead to AIDS. Depending if it's HIV1, HIV2, the time to AIDS is longer with HIV2 variants or than HIV1. But the truth is that the natural history, without intervention, every HIV positive person will ultimately lead to AIDS. But once you are on drugs, I tell my clients, I don't call them patients because they are not sick. They only picked up. I don't call them. I tell my clients that once you are on drugs, you are as good to me as somebody who will not have HIV. Once you can take, and what is there in taking a tablet in a day? The new formulation of drugs we are getting are drugs that are so easy. You don't have to take so many pills in a day. Just one tablet in a day. If you tell a woman not to put lipstick in her mouth every day, she might feel very, very bad. So what is there in taking just a tablet in a day? You understand? So with drugs, our goal is that nobody gets to HIV and AIDS. If you take your drugs very well.
Okay, so let's going back to the UNAIDS report. New HIV infections among children have declined by 51% since 2010. What do you think is the situation?
The intervention, it is declining too. Nigeria is getting it right, but we have not gotten to where we want to, 0%. You understand? Like I said, countries like Cuba went very strict with their prevention for mother to child transmission. But in our own culture, in our own time, we have our peculiarities. The first peculiarity is that you cannot tell everybody not to breastfeed. But even at that, once the mother is on drugs, she's doing well, the risk is reduced. At the same time, you cannot tell everybody to go for cesarean section. That is not even the challenge. The major challenge is that many women are giving birth without going to antenatal. Many women are giving birth in the villages. Many women are just so if these cases are not reported, that is our challenge. It's only when the baby is sick that the mother and the father is tested. So people should, HIV testing services is something that is free in most centers in Nigeria. So I think people should key into it. But we are getting it right in our PMCT, and I believe very soon we'll get there.
Okay. I just been able to get onto Facebook, and somebody here is asking, that should be AK Ahmaj. She's referring actually to what we talked about earlier about young girls getting HIV mostly from adult men. She's asking you to talk a little bit more about that. How does that happen? Why is that such a concern?
Why young girls get
HIV from
HIV
adult men?
from adult men? You see, a girl is 12 years. You understand? She's 13. She's most likely going to have sex, unprotected sex, with an adult who is older than her, who more likely has had other multiple partners. You understand? Maybe this is her first time, but she, unlike if it's a guy, is most likely maybe he will having sex with a younger population who is less at risk. So when and women are doing this is the same population of girls who are raped. You understand? These are girls, people who are sexually violated and cannot complain, and it's a sustainable thing. These are girls who are beginning to realize that they can actually get merits just because men are looking at them differently. They are not developing. And this man is now prepared to give me this just to come and sit on his lap. So these are issues here. I said aside the biology of the fact that a woman is more liable to have because she has an open genitalia. And let me also say this, that sexually transmitted infection is not every time a man sleeps or somebody sleeps with a HIV positive person, even if the person was not on drugs, that he gets HIV. It's not true.
It's a matter of
it's
chance.
No, I said it's not every exposure. Every exposure does not give you 100% chance of getting HIV. Every unprotected sexual intercourse does not give you 100% exposure. If it's a man, some studies are saying maybe if you have sleeping with a positive person, maybe out of every 10 times, chances are about 3 to 4 times that you might get HIV. Unlike a woman who might get up to 7 out of every 10 exposure. So by exposure, the chances remain. So the more unprotected sexual intercourse one has, and then but there are other issues that are surrounding it. If the person was raped, if the person has sexually transmitted infections, other ones like herpes infection, those will increase the chances.
Okay, two people are asking exactly the same question. Abdullahi bin Ibrahim Ayegba and Musa Bako Wara is asking. They are asking, what are the signs? If we just say those briefly.
Okay, so the signs. Let's look at one. The number one. If you have in staging, you have 4 stages, stage 1 to 4. Understand? In the first stage 1, you can have no sign at all. It's symptomatic, no sign. That's why HIV they show for face. In some people, what they call PGA or persistent generalized lymphadenopathy. They have these small lumps around in different lymph nodes. You understand? Yes. So those are the stage 1. But in stage 2, the earliest signs you will notice is that you've lost weight. Now look at it. If you lose less than 10% of your weight, for instance, if you're a 70 kg man, 10% of 70 is what? 7. So if you have lost 5 kg, it's less than 10% of 7. You understand? So if you're 70 kg and you're 65%, no other known issue is causing you to lose weight. You know, as if you are checking your diet. Less than 10% puts you in stage 2. You understand? If you have what they call herpes zoster infection, and you see people who have already had chickenpox earlier on in their life, they begin to have a sore. This sore characteristically does not cross the midline. It crosses from one part and goes to the back. In medicine, we say it follows the dermatome. It's very painful sore. That is not an absolute. Doesn't absolutely mean you have HIV, but other causes can cause it. But other forms of immunosuppression can cause it. But when you begin to lose less than 10% of it, you have sores like herpes zoster, so you have recurrent respiratory tract infection, always coughing. You understand? You begin to check yourself. You understand? You feel you have fever of unknown origin, less than 1 month. You always have fever. You've treated malaria, the fever is there. You have fever is there, so you begin to say you are in stage 2. In stage 3, it's no longer less than 10%. It's now more than 10%. So if you're 70 kg and you're now 60 kg, you've lost more than 7 kg. Without any cause, the red flag is up. You understand? If you're having fever for more than 1 month, the red flag is up. If you're having watery stool, diarrhea, always having diarrhea for more than 1 month, that is stage 3. If you're having other TB has a very good relationship with HIV, so that is also stage 3. If you're having what they call oral thrush, people can either not swallow. You see a whitish growth on your tongue. You understand? Always growing off. And if you are swallowing, you feel pain while swallowing. But you see, the chronic disease, we should stop waiting for the signs. We should go and get tested.
Okay, this is from Abubakar Kalgo. He says, I think it's a man. He's saying that the HIV spread in Lagos State is alarming because, to my own understanding, it's like people start to forget HIV and AIDS. It's like we are too reluctant and having unprotected sex. People need more enlightenment.
I think that, like I said earlier to you, even in the villages, people know about HIV. That knowledge you have, is it bringing about a behavioral change? That's my problem. The previous enlightenment, yeah, it seems that HIV is being downplayed. Thank God, in about 10 days from now, we'll be having our World AIDS Day. We're going to use occasions like that to stimulate government awareness campaign. But I keep saying it. I think that awareness should, as well as awareness is ongoing, people should not just stop at awareness. People should begin to impact, make sure that the awareness is enough to bring a behavioral change. If not, that is when the professor with all his degrees will begin to be having unprotected sex and be on the same level with the man in my village without education. Okay. Because he has information, it has not brought about a behavioral change.
Okay, I still have one more question from Jamila. She's asking, can I take antiretroviral drugs even without being positive?
There's two conditions where you can take antiretroviral drug without being positive. First of all, I told you there are issues where you have pre-exposure prophylaxis. You understand? Pre means before you got HIV. Some people are taking them antiretroviral drugs daily to protect themselves. So the high risk people are the female sex workers. We are advocating that the female sex workers, if they keep taking it, especially the brutal and the non-brutal based ones, they should taking these drugs. It will reduce the chances of them getting it or even infecting others. Yes, the IDUs and even those in the hospitals, because doctors, nurses are also high risk people. They should take them. The second set of people who take the antiretroviral drug without being HIV positive are patients who are post-exposure prophylaxis. You have issues where you are working in the theater, you accidentally get pricked, or you are raped. If you are raped and you cannot catch the person that raped you to do HIV testing, please assume the person is HIV positive. Okay. And place yourself on 28 days of antiretroviral drugs. Those are the kind of people who take HIV drugs outside that. If not, antiretroviral drugs are basically for patients who have HIV, except you are you're under pre-exposure prophylaxis or you are post-exposure prophylaxis.
So, just let me play the devil's advocate here. These aren't drugs that you can just buy over the counter, right?
All right, so they're offered in all. If you present yourself, now that's something I must put in. For the post-exposure prophylaxis, it is useless. The chances of its efficacy is highest if you can come within 72 hours. You understand? Within 72 hours after you were raped or after you got or you got exposed to infected blood, within 3 days you can come to the hospital. So these services are offered in the hospital setting. You cannot offer yourself, sir, because you may not even know the names of the drugs. So present to the closest health facility you have and explain to them. These are drugs that are offered in most government hospitals. All AHF centers globally will offer these services freely. So these are not things you should not just buy, because it goes beyond just taking the drugs. First of all, we need to do your HIV testing first. We need to assess your risks, then give you the drug, then follow you up again.
Okay, so let's bring it gradually to a close now. We'll go back to the UNH report, which is strongly urging countries, including Nigeria, to fast-track HIV prevention, testing, and treatment in order to end the AIDS epidemic as a public health threat by 2030. In conclusion, what's your sense of how Nigeria can key into this?
Nigeria can very much key into it by looking at inwards now data to find out that people who fuel the data, who fuel the incidence and the prevalence of HIV are the young women and girls. We should focus on the key population of young women and girls. We should focus on those who are also the female sex workers. We should we should stop depending on foreign donors. We should stop depending on. Nigeria has the capacity to fund and take hold of this HIV programming, because we keep begging. And even for the foreign donors that bring them, we are hearing issues of corrupt practices among them. So we should own up to take over our programming, fund our programming, and we should look in. That's what AHF is doing tomorrow. Tomorrow we will be in the Millennium Park trying to create awareness for people who are at risk. The people who have the highest burden, the age limit are young women and girls 15 to 24. We want to boost their capacity. We want to state awareness of all those challenges they have. We want to want to overcome them. I think that is one way, taking over our programming and then focusing on the key population. That will go a long way in our achieving our 2020 vision, 2020 targets.
Dr. Kema Onu, clinical coordinator for AIDS Healthcare Foundation. Thank you very much for being with us on Delicious TV.
Grateful.
Yes, and you can watch out for our social media cards to let you know what guest is coming on and when and what topic we'll be talking about.